monitor display actually now.
I don't know, let's just try the video, see what comes up.
I think it's going to be a little screwy, quite
The
frankly.
iGel is a novel and innovative supraglottic airway management device made of a medical-grade thermoplastic elastomer, which is soft, gel-like, and transparent. It took over 5 years of development to perfect a non-inflatable anatomical seal of the pharyngeal, laryngeal, and perilaryngeal structures that would reduce compression trauma. A supraglottic airway without an inflatable cuff has several potential advantages, including easier insertion, minimal risk of tissue compression, and stability after insertion. iGel is a latex-free single patient use device that has a gastric channel to reduce the risk of aspiration. Key components and their function. The soft, non-inflatable gel-like cuff matches the shape and softness of the laryngeal and perilaryngeal framework. It helps to provide easy and rapid insertion and reduces the potential for post-operative trauma. An integral gastric channel is provided to reduce the risk of aspiration and allow for passing of a nasogastric tube. The buccal cavity stabilizer eliminates the potential for rotation and aids insertion. An epiglottis blocker helps to prevent the epiglottis from downfolding or obstructing the distal opening of the airway. The 15mm connector extends inside the airway tube far enough to provide an integral bite block. Pre-insertion preparation. iGel is supplied in a sterile pouch enclosed in a protective cradle. This innovative packaging is colour-coded for size and designed to ensure the device is maintained in the correct flexion prior to use. It also acts as a base for lubrication. Select the appropriate size iGel according to patient weight. For patients between 30 and 60 kilograms, a size 3 should be selected. For patients between 50 and 90 kilograms, a size 4 should be selected, and for patients above 90 kilograms, a size 5 should be selected. When selecting size, it should be remembered that the iGel cuff does look smaller than the corresponding size of many traditional supraglottic airways with an inflatable cuff. Ensuring that you conform to local policy for hygiene, open the iGel package and on a flat surface take out the protective cradle containing the device. In the final minute of pre-oxygenation, remove the iGel and transfer it to the palm of the same hand that is holding the protective cradle, supporting the device between the thumb and index finger. Place a small bolus of water-based lubricant, such as KY jelly, onto the middle of the smooth surface of the cradle in preparation for lubrication. Do not use silicone-based lubricants. Grasp the iGel with the opposite free hand along the integral bite block and lubricate the back, sides and front of the cuff with a thin layer of lubricant. This process may be repeated if lubrication is not adequate. But after lubrication has been completed, check that no bolus of lubricant remains in the bowl of the cuff or elsewhere on the device. Avoid touching the cuff of the device with your hands. Place the iGel back into the cradle in preparation for insertion. Do not place the device onto the pillow or chest of the patient, and always use the protective cradle provided. Do not use unsterilized gauze to help in lubricating the device. Do not apply lubricant too long before insertion. And always ensure dentures or plates are removed from the mouth before attempting insertion. The iGel must always be separated from the cradle prior to use. The protective cradle is not an introducer and must never be inserted into the patient's mouth. Insertion technique. A proficient user can achieve insertion in less than 5 seconds. Remove the iGel from the protective cradle and grasp the lubricated iGel firmly along the integral bite block. Position the device so that the iGel cuff outlet is facing towards the chin of the patient. The patient should be in the sniffing the morning air position, with head extended and neck flexed. The chin should be gently pressed down before proceeding to insert. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force on the device during insertion. It is not necessary to insert fingers or thumbs into the patient's mouth during the process of insertion. If there is early resistance during insertion, a jaw thrust or insertion with deep rotation is recommended. When inserted to a definitive resistance, the tip of the iGel should be located into the upper esophageal opening, and the cuff should be located against the laryngeal framework. The incisors should be resting on the integral bite block. Since iGel is shorter than many other supraglottic airways, it is important to remember that after correct insertion, it is likely that less of the airway tube will be visible. The iGel has a horizontal line on the integral bite block to indicate the optimal position of the teeth. But the teeth may rest safely anywhere on the integral bite block. The iGel should then be taped down, maxilla to maxilla. When inserting the iGel, it should be remembered that partial resistance and then a feeling of give way may sometimes be felt before the endpoint resistance is met. This is due to the passage of the bowl of the iGel through the forcial pillars. This is quite normal and consistent with correct insertion, but in such cases, insertion needs to continue until definitive resistance is felt. Let's look at some iGel insertions in real patients. Note the sniffing the morning air position and the gentle press down on the chin. See how there is no need for fingers to be inserted in the mouth. There is never a need to apply excessive force or to repeatedly push down on the device once definitive resistance has been felt. How to use the gastric channel. If required, a nasogastric tube can be inserted down the gastric channel of the iGel. For a quick and efficient insertion, it is important that the nasogastric tube and the gastric channel of the iGel have been adequately lubricated before insertion is attempted. The ideal way to achieve this is to place a small bolus of lubricant over the proximal end of the gastric channel. The nasogastric tube should then be inserted a short way down the channel and moved in and out to prime it before completing insertion. The maximum size of nasogastric tube that can be inserted down the iGel is size 12 French gauge for a size 3 and 4 iGel, and a size 14 French gauge for a size 5. In summary, iGel is a simple and effective alternative to traditional supraglottic airway devices. iGel has been designed to eliminate the need for an inflatable cuff and create a superior anatomical seal mirrored to the pharyngo-laryngeal structures. It includes a gastric channel to reduce the risk of aspiration and is very easy and rapid to insert. iGel offers natural airway management.
So sorry for the technical difficulties earlier. So I just see the iGel has some pretty definitive advantages over a typical LMA. Now currently here in BC, what's happening is that we're doing a trial with BC Ambulance, and you may be seeing these airways coming in on the trucks. So I'm sure you guys are all aware of the King tube. Right now, BC Ambulance is looking at this tube to possibly replace the King tube, or at least have it on the truck as an alternative. As you can see, one of the biggest benefits of this tube, especially in emergency situations, is how easy it is to insert. You don't have to have extra syringes around. In situations like, say, like in Whistler, for example, where it's cold, the integrity of balloons can be an issue with colder temperatures. There's actually there's a doctor in Alberta that's actually he's a medical director at Sunshine. He's actually writing a paper comparing the King tube to this tube under those circumstances. So again, that's applicable, can possibly be applicable to BC as well, not necessarily Vancouver. You guys might think today is cold, but I came from Edmonton, it's -25, so I'm happy to be here. But otherwise, yeah, it's a really easy tube to insert. It's the big differences again, just to reiterate. Sorry.
Can you come on over here to the
Sure.
mic so that
Oh,
other sites can hear you?
Oh, okay. I don't know. I thought I was really loud anyway. You can't hear me? Sorry. So just to reiterate, there is no cuff. There's no potential. So one of the reasons why it's so easy and fast to insert is the fact that there is no cuff. When you put a cuff in, you have to deflate it and then inflate it. Also, there's potential trauma and dislodging of the device associated with that maneuver as well, which is eliminated. The integral bite block and the ability to suction are like the key components that kind of differentiate it from other devices. So this is used in the OR. Important to note is that you can perform fiber optic, you can perform intubation under fiber optic abilities with this. The size 5 will take up to a size 8 endotracheal tube. You can also use a bougie and then just do your regular railroading technique. So typically in the hospital right now across Canada, you're seeing these in crash carts. They are being used in the OR for LMA just because there are increased studies showing that there's less sore throats, there's less blood on the airways post-op when they're pulled out. There's less trauma just because of the gel-like material that the cuff is made from. And the fact that it's not inflated, you're not having that extra pressure on the perilaryngeal framework, you're actually causing less damage. So there is a website. iGel has its own dedicated website, www.i/gel.com. On there's a ton of information. There's over 250 studies and review articles about this, and you can actually go in there, have a look. I have the abstracts printed off. I'll leave it with Chris to have in the department, as well as the user instructions. As you can see, it's very simple to use. You generally can read it and be able to use it. It's really that simple. But in the bibliography, on the website, if you were to look at something, if you were interested in a certain area, sore throat, or comparing this to another device, likely the study's been done and you can go in there and have a look. Any questions? Pretty standard. I see you guys are very excited about the second generation iGel.
Thank you.
Yeah, no worries.
Okay. Thank you, Melinda. Do you want to? So do you remember where he had you attached? Is it this one?
Yeah. So you're good, Greg.
Sure. Jim, are you comfortable with this? So we're having some technical issues this morning. I'm glad I brought 4 copies of my presentation on different USBs, internet, and computers.
Sorry, this is
hers now. This is Laura's.
okay. This is on VG.
So it should go
Off
there.
it in here. Lectern VGA, which should be good. Just leave it there. There.
Okay. Do you want to grab Laura? She's at knowledge.
No, it's not. The right thing up there yet.
So next we have Dr. Laura Miller. She's one of our R3 residents, and she's going to be presenting on VT electrical storm. It'll just be a second as it loads up. No, because it's not on presenting. Can you grab Greg, actually? Oh, yeah. Okay, so my topic is electrical storm, aka ventricular storm, aka refractory VTAC, and VFib. This was inspired by a case that I saw on CCU recently. So, 68-year-old male with central chest pain radiating to his right arm that feels like his previous MI, also had 8 ICD shocks with a possible decreased LOC. He's coming in with EMS, and he's at 150 of IV amiodaron en route. In the resus bay, he's alert. His heart rate is 60. BP is 119 over 65, a bit tachypnic at 33, but sats are good, 100% on room air. Afebrile, glucose is 10. Past medical history includes ischemic heart disease with a previous NSTEMI, complicated by VT-VF arrest, with multiple presentations for recurrent VT, requiring several complicated PCIs and an unsuccessful ablation. He has ischemic cardiomyopathy with an EF of 20. He has an ICD in place. He has hypertension, paroxysmal AF. He's had DVTs. He's got CKD. His home meds include amiodaron, mexiletine, bisoprolol, and rivaroxaban. He's full code. Investigations include potassium of 5, lactate of 6.6, creatinine of 127, first trope is 43, and ECG shows ventricular pacing at a heart rate of 82. Shortly after arrival, the patient develops VT again. He becomes pulseless. With cardioversion, he goes back to a pace rhythm and he wakes up, but after 30 seconds, he's back into VT. So usually it's monomorphic, but sometimes it looks like polymorphic or maybe even VF. He receives 14 external shocks at 200 joules within a time span of 13 minutes. And his ICD also fires several times. In fact, his ICD is recorded as firing over 20 times that day. Medication-wise, he receives ASA, nitro SL, repeat amio bolus at 150, lidocaine 100 milligrams. He gets a gram of procainamide. He gets 4 grams of mag-sulf and 5 milligrams of midaz. Finally, the dysrhythmia ceases. He's able to be intubated with just 50 milligrams of ketamine and no paralytic. He gets a bit of post-intubation hypotension for which he's given phenyleph. A norepi infusion is started. He's also started on a propofol infusion, and the dispo is cath lab / CCU. So what we'll talk about today is just briefly definition, etiology, and classification. Brief overview of management, so anti-arrhythmics, sympathetic blockade, a touch on electricity, a touch on other interventions, and then to bring it all in together, a simple ED algorithm. So, electrical storm is a medical emergency with a clustering of ventricular arrhythmias in a short amount of time. There's no universal definition, but AHA describes electrical storm as a state of cardiac instability defined by 3 or more episodes of sustained VT, VF, or appropriate shocks from an ICD within 24 hours. So some of the definitions also include incessant or refractory ventricular arrhythmias. Clinical presentation ranges from palpitations, dizziness, and syncope, all the way to cardiac arrest. Electrical storm is associated with increased mortality. It's considered at least an adverse prognostic factor, and it's postulated that the arrhythmias and the shocks might contribute to cardiac injury and progression of heart failure. Underlying etiologies include structural heart disease. So this includes ischemic cardiomyopathy with or without ACS, with or without a recent or remote MI, as well as non-ischemic cardiomyopathy. So things like arrhythmogenic right ventricular dysplasia, valvular disease, myocarditis. It also includes electrical pathology with things like Brugada and long QT. So electrical storm is classified based on 3 ECG morphologies with clinical implications. So monomorphic VT accounts for around 77%, and it's commonly due to structural disease. Polymorphic accounts for 7%. If you have a normal QT based on the sinus ECG, it's most likely ischemia. If you have prolonged, and it can, of course, be congenital or acquired, VF accounts for around 11%. It has a very high mortality rate at 85 to 97%, and it's often due to ischemia. So just to look at the overall approach to management, the initial approach is, of course, ABCs, follow ACLS, and consult cardiology early. Now, if you have a symptomatic, unstable, or pulseless patient, or those with polymorphic VT, or VF, all of them require immediate electricity. You can also consider electricity as first line for stable VTAC. If there's known or specific diagnoses, like, for example, long QT or Brugada, those have different management that we don't have time to cover today. So 10 to 25% of electrical storm cases do have identified reversible causes, so you want to target these if possible. So this includes acute myocardial infarct or ischemia. The most effective treatment for this is to reverse the ischemia with revascularization. It also includes new or worsened heart failure. It includes electrolyte abnormalities, so most commonly magnesium or potassium being low. It includes medication or toxic effects, hyperthyroidism, and infection. So just a brief look at antiarrhythmics in general. There's something called Electra. It's an open enrolling registry. And so as per the data they have so far, it looks like amiodaron is being used in 73% of cases, beta blockers in 60% of cases, lidocaine 37%, and sedation itself in 11%. Most ventricular arrhythmia studies are retrospective and small, and there's limited studies actually based on acute management. So most of them are looking at long-term suppression of ventricular arrhythmias, or they're looking at the stable VTAC population, or they're looking at cardiac arrest. So the existent studies are complicated by differences in inclusion of ACS, hemodynamic instability, and cardiac arrest. And there's also significant differences in dosing between studies. So what do we have for guidelines? The AHA released new guidelines just in November 2017 on ventricular arrhythmias. And then, of course, we have the ACLS guidelines 2015, although no significant changes for ventricular arrhythmias from the 2010 version. So up first is amiodaron. Now, when you're looking at the acute IV formulation, what you're mostly getting is sodium and calcium channel blockade. Now, this is widely used in the acute management of electrical storm. In patients with a pulse, we have very few studies with very few patients comparing amiodaron to other antiarrhythmics. The 2017 AHA guidelines do make a strong recommendation for IV amiodaron for shock-resistant, unstable ventricular arrhythmias. Now, they're basing this recommendation on the 3 RCTs that we have of amiodaron in the context of out-of-hospital cardiac arrest. So one of those trials showed that amiodaron had improved survival to hospital admission compared to placebo. Another showed the same thing, but compared to lidocaine. But neither of those trials showed advantage in survival to discharge or to favorable neurological outcome. The most recent we have is 2016, so that's the ALPS trial, over 3,000 patients. Now in this one, neither amio or lidocaine improved survival to discharge or neurological outcome compared to placebo. But if you look at the subgroup of witnessed out-of-hospital cardiac arrest, they did improve survival to discharge. And interestingly, both medications did facilitate the termination of ongoing recurrent ventricular arrhythmias with fewer shocks. Notably, there was no differences between the 2 medications in this trial. Some people think this trial was underpowered to show actual differences. It's definitely a huge area of controversy, but as per the current guidelines that we have, amiodaron does remain first line. So as we know, of course, the dosing is 150 milligram bolus, and then you start your infusion at 1 milligram per minute for the first 6 hours. But note that you can give repeat boluses, as long as you don't go past the 2.2 grams in the 24 hours. Okay, up next is Procainamide. So this is primarily a sodium channel blocker. There's 2 main studies comparing Procainamide to amiodaron.
but both of them are actually in a bit of a different population. It's the stable VTAC population. So the only prospective trial is Procainamide. So this is 2016, 62 patients, and it showed that Procainamide had less hypotension and more effective termination of VT compared to Amiodaron. So at 40 minutes, and it was 67 versus 38%. So AHA, the 2017 version, does make a moderate recommendation for using Procainamide as first line when you have hemodynamically stable VT. The ACLS guidelines from 2015 still just say to consider it in their general recommendations for wide complex tachycardia. Quick note about dosing. Of course, the ACLS dosing is the 20 to 50 milligrams per minute with that max of 17 milligrams per kilogram. Some people are advocating using a bit of a more rapid load. So, for example, in Procainamide, they did 10 milligrams per kilogram, but over 20 minutes. And some people are saying even over 10. So that works out to be the 50 to 100 milligrams per minute instead. So you can do that. Some of the local cardiologists mentioned they find they have more hypotension with that, and then you just want to slow your infusion down if you are getting hypotension. So quick reminder that stop points include hypotension, QRS prolongation greater than 50%, or a worsening, so an acceleration in your tachycardia. So lidocaine is, of course, another sodium channel blocker. Now, there's decades of controversy comparing lidocaine to the other antiarrhythmics. There's several small studies showing it's less effective than the other agents. There is this theory that lidocaine might be particularly effective in ischemia, but there's insufficient studies to draw conclusions around that. The old guidelines, so AHA 2006, did recommend lidocaine as a first-line antiarrhythmic in the context of ACS. That's not reiterated in the 2017 guidelines. They don't specifically say which one to use in the context of ACS. Now, they are recommending lidocaine in the context of witnessed cardiac arrest that's not responding to defibrillation, vasopressor, CPR when you have polymorphic VT or VF. ACLS just recommending it as a second-line agent. So looking at magnesium, it's only formally recommended for polymorphic prolonged QT or electrolyte abnormalities, but anecdotally it seems to be given often empirically for many types of ventricular arrhythmias. And you also ideally want to keep your potassium between 3.5 and 5. Next up is beta blockers. So recurrent episodes of ventricular arrhythmias elevate your sympathetic tone, which increases the frequency of subsequent episodes, setting up this vicious cycle. So suppression of adrenergic tone is considered by many to be a mainstay of therapy for electrical storm. There's lots of studies looking at long-term suppression of ventricular arrhythmias using beta blockers, but not very many for acute management, despite it being widely recommended. So there's an often quoted trial, prospective, non-randomized, with only 49 patients that compared beta blockade to ACLS, and they found improved mortality, 82 versus 22, and improved one-year survival, so 67 versus 5. And then there's this another prospective non-randomized trial with 42 patients using a really short-acting beta blocker. This is in Japan, landiolol. And they found that it was effective in 79% of patients that were refractory to standard antiarrhythmics. Now, if we look specifically at the population of refractory VF, there are several retrospective studies with a small number of patients that looked at esmolol. So one of them had 6 patients getting esmolol out of 25, and they had improvement in ROSC and admission, and they also had improvement in survival to hospital discharge, as well as neurological outcome. So 50% versus 11%. There was another small study with 16 out of 41 getting the esmolol, and they found improvement in ROSC, improvement to admission, but no improvement in neurological outcome. So a larger prospective trial is needed. Currently, the AHA is making a recommendation at a moderate level for IV beta blockade for polymorphic VT due to ischemia or electrical storm with a recent MI that's refractory to electricity and other antiarrhythmics. They're not making specific recommendations for beta blockers. Now, notably, despite this sort of specific recommendation, in general, reading through the literature and asking the cardiologist and asking around other emerge physicians, critical care, beta blockers are quite widely recommended in electrical storm. As we know, contraindications include decompensated heart failure, hypotension, and cardiogenic shock. One nice option is esmolol. has a rapid onset, short duration of action. So the dosing is 500 mcgs per kilogram bolus, and then you do 50 mics per kilogram per minute as an infusion. Next, we're going to talk about other ways to decrease the sympathetic drive. So sedation itself is an effective strategy. You can consider short-acting benzos, propofol. There's a case report showing propofol was associated both with termination and suppression of ventricular arrhythmias, plus or minus intubation. In the literature, general anesthesia is also recommended. And there's actually also procedures to reduce sympathetic drive. So these are less commonly used, but they include percutaneous ultrasound-guided stellate ganglion block. Now, I found this mostly in the anesthesia literature, but it is percolating into the emerge world. There's a meta-analysis that did not identify 38 patients, and it did show a decrease in arrhythmias and shocks. Asking around, it sounds like this has been done rarely, but it's actually been done by thoracics at SPH. Other approaches include epidural anesthesia and surgical cardiac sympathetic denervation, but that one's obviously not going to happen acutely. So looking at electricity, quick note on overdrive pacing first. So this is an option, but it's not commonly used. There's very few studies evaluating its effectiveness in the ED. You have to set the pacer rate 20 to 60 beats per minute above the dysrhythmia rate, and it's thought that it won't work very well if cardioversion itself is already not working. Another strategy for electrical storm is to consider increasing the amount of energy during shocks. So double sequential external defibrillation has been described in many retrospective studies, mostly specifically for refractory VFib. It's unclear if it works by changing the vectors or just by increasing the amount of energy. So studies do look promising for conversion and for ROSC, but it's not clear at this point if it improves neurologically favorable survival. I also found one case, it's actually Annals of Emergency Medicine this month, using double sequential for cardioversion for VT, but it didn't work, and it also wrecked the defibrillator. So this is currently off-label. But if you're going to try it for refractory VFib, the pad placement is a few different options. So you want to do either both AP beside each other but not touching, both AL, or one of each, and then you press the buttons at the same time, just count down. Other interventions include bridging with mechanical support. So intra-aortic balloon pump has been used, LVAD has been used, and ECMO, which has been used successfully in refractory VF and VT arrest as a bridge to further treatment, especially if the further treatment is the cath lab. Catheter ablation is also an effective management and can be an acute effective management when antiarrhythmics are not working, but mostly this would happen from CCU and not directly from the ED. So there's lots of very complicated algorithms out there, and a lot of them are based on ECG morphology. So they'll right off the bat divide into the monomorphic, VT, polymorphic, and VF, but they get pretty complicated. So just keep in mind there is specific management for different types of long QT and for Brugada. But just to provide a nice simplified approach to an ED algorithm, this is one of them here. So you've got your electrical storm. You're, of course, going to start with ACLS. You're using electricity. You're going to consult cardiology and cath lab early, because remember, cath lab is what's going to stop the ventricular arrhythmias in a lot of the cases. And keep in mind there's different management for polymorphic, long QT, and Brugada. Of course, you're going to start with your amio bolus at 150, but keep in mind you can do additional boluses as long as you're not going past that 2.2 in 24 hours. And you want to make sure you start that infusion as well. So it's 1 milligram per minute for 6 hours. You want to consider other antiarrhythmics. So there's really no good evidence or even guidelines to decide which antiarrhythmics go well together and when. So you're just going to have to use clinical judgment. Remember beta blockade. So a nice option is esmolol, starting with that 500 mcgs per kilogram bolus, and then the infusion at 50 mics per kilogram per minute. But you can also try metoprolol, just at the standard 5 milligrams IV, and also propranolol, a lot of different options for beta blockers. Now, you also want to remember to look for reversible causes. So you're looking for ACS. You're looking for decompensated heart failure. You're looking for culprit medications, and you're looking for electrolyte abnormalities. So this particular guideline had ischemia specifically for ACS, but remember, lidocaine is an option for an antiarrhythmic, even if you're not suspecting ACS. And then consider sedation. So propofol, benzos, plus or minus intubation. This in itself can be a really good strategy to decrease that adrenergic drive. And then if you get down this low, you might want to think about mechanical hemodynamic support. And of course, DISPO is CCU/cath lab. So this just to show you what it looks like, this is just the info that I already put up there. This is from a 2015 review article, but I wanted to draw your attention to the Tex Heart 2011 review of electrical heart. So if you just put in Tex Heart 2011 electrical storm, I think that's a really fantastic review of the subject. Let's review the case. So in follow-up, this patient was sent to the cath lab. He got there 4 hours after arrival to the ED, and he had a new stent placed in his again restenosed OM. His EF was unchanged around 20%. It was thought that ischemia was the likely culprit for his electrical storm. He actually had no recurrence of ventricular arrhythmias in the CCU. He was weaned from pressors. He was weaned from propofol. He was weaned from the IV antiarrhythmics. And he was started just on his home doses of PO, antiarrhythmics, and heart failure meds and discharged home. Although, unfortunately, he came back a week later with more ICD shocks and decreased LOC. He's quite a complicated patient. So take-home messages are start with ACLS. Do what you're already doing. Amiodaron is currently the first-line antiarrhythmic, but consider beta blockade. Consider sedation as well to decrease adrenergic drive. Of course, consult cath lab cardiology early. And in that population of stable VTAC, Procainamide, based on the one RCT we have, is currently first line. Thank you.
Are there any questions for Laura?
Yes.
Does anyone know if we have Esmolol? I've asked for it a couple times.
Oh, really? I did not ask for it.
I'm curious to the staff or anyone. Anyone had success? Okay.
Yeah. The review articles and the literature really seem to lack specific recommendations. So I saw a bunch of case reports. There was metoprolol, there was propranolol, and there was esmolol, which is actually mostly in the refractory VFib population. So I asked around with the cardiologists. They all said different things. Yeah.
I just...
That's true. I think the thought was he seemed unstable. I kind of walked in a few minutes before that happened. And I think it's just because he had been losing his pulse like so many times. It was for stability, but they felt he needed a little something. But yeah, good point.
Hi, Laura. Thanks for a great talk. Was there any point, did they question whether the ICD was working? And can you shock someone with an ICD? And was it shocked?
I had it, just to cut it down, I cut out the little ICD section. But basically with ICDs, it really doesn't change your management in the ED. So you just, if it doesn't shock, then you go ahead and shock. And remember, some of those ICDs, when you're looking at electrical storm, it can be anti-tachycardia pacing, where it actually tries to overdrive pace, or it can be a shock. That counts as electrical storm. But basically your initial management is the same. So if the ICD doesn't go off, then you need to shock. And then the CCU will interrogate the device. And it was doing it appropriately at over 20 times. Sorry, I think I missed your question.
I guess the question is, if it goes, it appears to go off.
Yeah.
But how do you know it's working? Like, is it bad?
Oh, in this case, you would go back into sinus. So you could tell if it worked or not.
I guess my question is, do you wait for cardiology to interrogate the ICD before shocking? Or
no.
do you just go ahead and
No, you just go ahead.
Even
so they
if you
had,
think the ICD is shocking?
Yeah, we got, on CCU, we got the call that was like, we've already shocked him 20 times and his ICD is going off. Okay. Come now. So by the time we got there, yeah. So you can definitely go ahead and shock and they can interrogate later. Awesome. Thank you.
So, this is the final talk of the morning. Miraculously, the IT worked. Thank you for your patience with that. There was a buffer of time, so we're okay for that. So for January Grand Rounds, we thought we'd kick off the year with an idea that I had read about in the Annals of emergency medicine and partially inspired by my father-in-law as well. You guys got the emails. This is an idea in contrast to morbidity or mortality rounds. So we have a tough job. Every month we look at what we could have done better with certain cases. We're striving for perfection. Those are such important parts of keeping ourselves accountable and in quality improvement and in becoming better emergency physicians and a better department as well. But it is tough because we don't always have time to celebrate the successes of what we are doing. We are constantly met from demands from different parts of our society. The patients are frustrated with wait times. The consultants are getting frustrated being called in the middle of the night. We don't necessarily want to hand over to our colleagues. We don't like receiving colleagues. There were so many other little comments I could have put up there, but I held myself back. It can be a tough job sometimes. We have high rates of burnout, perhaps sleep disorders, higher rates of malignancy over time. I mean, it is a hard job. So, partially inspired by this Annals of Emergency Medicine article that said, why don't we flip morbidity mortality rounds on its head and look at what we've done awesome and amazing in the department. This is also partially inspired by my father-in-law. He is a really eccentric guy. Some of you have had the pleasure of meeting. In the 70s, he did his PhD in nuclear physics at MIT, went on to work at Max Planck Institute in Germany, and then ran Canada's nuclear fusion program with the NRC. He describes, though, when he did his PhD, there was a 50% failure rate. There were 10 of them going through as a cohort. They got to their defense, and they'd wait for their friends to come out, and they'd look at their faces, and behind their back, they had either a bottle of champagne or a bottle of whiskey. And which one was it going to be? And I think we go on shift every day and we're a little bit worried. Is that patient going to be a bottle of champagne? I'm going to get the diagnosis, figure out the dispo quickly, or is it a bottle of whiskey? And it's sometimes a bit tricky. So we don't always get a chance to thank each other. Sometimes what is expected of us is really remarkable. And sometimes medicine is just darn cool. So it's January, New Year's just happened. I thought it would be fun to drink a bit of champagne. Okay, so we're going to go through a few cases. I was actually sent over twice the number of cases that I'm going to present. We're going to touch on a few people in the department as well, just more of a lighthearted way to bring in the new year. I hope that you look at these and you think, I could have done that, I've had that, or it reminds you of something positive. For me, it was really fun to prepare this presentation because it's just a more positive approach to what's going on in our department. So this case was a physician nominated a resident for this case. It's a 37-year-old that comes to your department at 12:30, just after midnight, and you see on the triage note that they've been seen earlier in the day for some renal colic. They had an ultrasound that showed a 2-millimeter calculus at the right UVJ, just a bit of hydronephrosis. The rest of the ultrasound was normal, appendix not seen. Sent home with oral ketorolac and Flomax. So the off-service resident picks up the chart, goes over and sees the patient, finds out that they've had worsening pain at home. The Toradol wasn't working so well. The pain's really radiating into the front of the abdomen, in the groin now, worsening nausea, some diarrhea. Their vital signs are unremarkable, but they are, with the exception of being febrile now. And their labs are normal. So on exam, they have right-sided CVA and right-sided abdominal pain. Their labs are unremarkable. So the resident is doing return of service, has been proactive to take their EDI course, decides to try to find that stone on ultrasound, and then they find free fluid in the abdomen. So this is reviewed with the attending, even though it's a little bit busy in the department, in the RAS area. And then proceed to a CT scan shows a perforated appendicitis and the stone in the bladder. So it was not a misdiagnosis, but an extra good catch by this resident. So this resident was amazing. They weren't anchoring on the first diagnosis. I think it is so easy when we see patients come back and they've been seen by a previous physician to assume that the first diagnosis was correct. The first diagnosis was correct in this case, but there happened to be a second diagnosis as well. We have a tendency to seek only as much information as we need, and then as new information becomes available, often we stick with the original diagnosis. So always remember, felt the tips to take home from this case, seeking out new information. We go over with our learners, always think of the 3 most common diagnoses, 3 most life-threatening. But sometimes, as it gets busier and busier in the department, we lose this cognitive awareness in ourselves, and we do just jump to that, what will fit into the nice, clean box as easily. And then working on techniques to develop cognitive awareness while on shift. So, high five. Nice job. So our next case, oh yes, Garth. So, and this case was in no means by meant. It's like the first. It was meant to celebrate. No, but I think, yeah. No, and I think that is a testament to what we all need to do as emergency docs as well, is that giving that careful follow-up advice is just perfect, because you can't CT everyone, and especially you can't CT every young woman coming in, because we'd be having a lot of radiation out there. Yeah, and without that advice, perhaps would not have come back. So, thank you, Garth, for bringing that up. So our next case is a 67-year-old woman. She's obese, a complicated medical history. I feel probably everyone's seen this patient. You can see the triage note there. They comment on a bit of hemoptysis, and now the tongue is swelling, but I guess they were vocalizing at triage, so perhaps the triage nurse had felt no airway obstruction there. Vital signs were notable for a high blood pressure, and you hear CTAS-2 to resus, and then you walk into resus, and this is the patient's tongue that you see. This is not our actual patient in the department, but this is our actual patient, so you can see that the tongue is enlarged. As the MD notes, this was a remarkably calm-looking woman, which is always nicer. The ERP comes to the bedside, finds the history that they've had a sore throat for a week, but this morning the tongue started to swell. She's sitting forward in the gurney, unable to swallow, and you happen to notice on her neck that she does have a prior Craig scar, and that was from a prior difficult intubation from a hernia surgery. So nothing to do with tongue swelling, but just, unfortunate, difficult airway at baseline. So the attending very appropriately goes ahead and prescribes some medications in case this is an allergic reaction, puts in a stat call to the ear, nose, and throat, who came down very promptly to the emergency department and attempted a nasopharyngoscopy. On this scope, they could see no cords whatsoever. So this suggests that an awake intubation even probably wouldn't, may not be successful. And at 1:30, she's in the operating room getting a trach. So I thought that was pretty remarkable. This is the type of case where things just happen as they should. Within 90 minutes of coming in, the patient is getting a definitive airway. And it's nice when things happen and they flow in the department. It's a little more anxiety-provoking when it doesn't happen. But this patient had angioedema. Help was called for early and preparing for the difficult airway. Angioedema, just by way of background and refresher, roughly about 40% of cases, or a bit over a third, we don't know the cause. A third of cases are allergic related, and so this physician, tried the allergic protocol, was unsuccessful. Usually if they're allergic related angioedema, they're going to have some other symptoms. So they'll have the urticaria, they'll have the wheeze, they'll have something else. And then the final third is bradykinin mediated, and that's more of your ACE associated angioedema and your hereditary angioedema. This patient had been started on an ACE earlier that month. Some interesting studies that show individuals who are on ACE, some people are more susceptible to this than others, but in those who had ACE-associated angioedema, their bradykinin levels were 10 times the level that they normally were when they were on that ACE. For some reason, while they're on this medication, it spikes. It increases vasodilation of the tissues where fluid shifts out in non-gravity dependent areas. So that's the key to angioedema. And even if you kept them on the ACE and you forgot to take them off, because I have had a ACE angioedema come back, they do get better with time, so 72 hours. So the key is really airway management. There are a few more experimental drugs. You can try Fresposum plasma, you can try icatibant, but that is not really prime time and that successful yet. So, amazing, 90 minutes. I thought it worked out very well. And the teamwork in this case, I think, was exemplary talking to the doc. So EHS was quick. The nurses were amazing. The MD was quick at assessing the urgency of the situation. The UC participating in tracking down ENT, and ear, nose, and throat was readily available. Sometimes things work. And just so everyone knows where the difficult airway kit in the resuscitation room, it's right there. So getting it out and open always wards off evil spirits and makes you feel more empowered and ready to cut if needed. So I had fun going through a bunch of Google reviews. There's a remarkably high number of positive ones to do with our department if you just go through the St. Paul's one, but I thought I'd show you a few. This person was clearly very happy with their care, and this was just this fall.
Carolyn.
Yes.
Did your father-in-law ever cause a 3-alarm fire with a root vegetable at an atomic plant?
You were going to get to that later.
Okay.
Yeah. So, high five, team. Nice job. Also want to highlight some rock stars in our department. This fall, they were having trouble looking for unpaid positions of BCIT mentors for rural nursing students, and Joy, Rod, Zabina, and Irene all stepped up to the task, and it's nice to have that engaged involvement in our department. High five. Okay, so 37-year-old presents with a sore throat. The triage note notes a bit of chest pain, but the vital signs are normal. The patient is triaged as CTAS 3 to RAS. Feel like we've probably all seen a few of these patients, especially in the last few weeks. I know I have. Oh, come on. Okay, so found to be 37-year-old, previously healthy with thalassemia minor, 2 days of sore throat. Sister's also sick, went to the Lionsgate Hospital, got some amoxicillin, and is frustrated because she's not getting better. I don't know if anyone else has seen this patient in the last month, but I feel like many of us have. Normal labs that had been ordered at triage. The vitals were normal, afebrile, supple neck, no trismus, throat is a bit red, but no exudate seen. So most of us probably would even feel that amoxicillin was overkill in this patient and perhaps send them home. But this physician's spidey senses went off, and we've all had those spidey senses, felt that the pain was a bit out of proportion to the findings on exam, so proceeded with a lateral soft tissue neck. And does anyone want to volunteer what they think of the soft tissue neck? Looking pretty good? Abnormal? Yeah, maybe the prevertebral space is a little bit wider. There's a lot of different formulas for this. I use 6 millimeters in front of C2 or 22 in front of C6. This happens to be 8 millimeters in front of C2. The patient then, with her normal vital signs, normal labs, goes on to get a CT of the neck, which shows a fairly large retropharyngeal abscess. So it's 5 centimeters by 2 centimeters by 1 centimeter. So it was a great pickup. It's nice when we can pat ourselves on the back. But this patient was referred to ear, nose, and throat. It's really up to the surgeons to decide if they're going to take this to the operating room. Still, in many cases, they monitor them for 24 hours, but it's more often done in a monitored setting as opposed to just sending them home on amoxicillin. So deep neck space infections. There's not any good guidelines to help us distinguish which is the most sinister sore throat from those that are not. We're all looking for trismus. We're all looking for a neck that seems, a little bit not supple, but it is hard to pick it out. So kudos to this physician. There's other sinister soft tissues infections of the neck. So we worry about a retropharyngeal abscess for its potential airway impingement, and also it can lead to very significant mediastinal infections, which are much harder to treat. Others, Ludwig's angina or Lemierre syndrome, like the septic thrombophlebitis of the jugular vein. We've had a few of those cases reviewed at our morbidity mortality rounds. But this one is at awesome and amazing rounds, not at M&M, so it's nice. Think polymicrobial. So the amoxicillin wouldn't not necessarily have helped this patient because you get more anaerobic and gram-negative infections there. So epic high five. Another review of St. Paul's, just in December, which felt so busy, but some people were happy. Good job. So high five. Another amazing person, our nurse Zoe. We have patients coming in from other facilities all the time. Sometimes when it's so busy, it's hard to stay on top of things, but she very diligently went through the MAR and caught multiple errors and was nominated for got the Good Catch Award on a hospital level after filling out the incident form. So nice job. Okay. 30-year-old, otherwise healthy cyclist. Should mention this was the physician's last patient of the shift, and I think after a busy shift where you go on acute and then you're on fast track and you tend to be seen, you're not always, as motivated by the last patient. Sometimes you're riskiest. So they have a right-sided testicular pain. After they had been vigorously cycling at the velodrome, there was gradual onset to this pain, no prior testicular pathology, no history of straddle injury or anything, really just a routine cycle as far as the patient could report. However, was very tender on exam. High-riding testicle, very tender, and the physician was suspicious for a torsion, attempted to reduce it, and was unable to. So at 10:30 at night, when it's your last patient, you're not always as motivated to push for that ultrasound, but they did push for the ultrasound and made a stat call to urology, and this indeed was a torsion. The patient was up in the operating room very quickly, and then walked out of the hospital the next day with 2 intact testicles, which I'm sure they were happy with. So, good job for this physician. So, tips to take home. But that last patient of the shift is always the riskiest patient, and kudos to this doctor for just taking a pause and still pushing for the appropriate care. If it was your first patient, easy, but you are a little more fatigued, so nice job. Pushing for the ultrasound at whatever time is needed when it is indicated. That's the best way to make the diagnosis. And thank you to our locums, because this was caught by a locum while we were all at the retreat. They were taking very good care of the department that night. So, torsion itself, the cremasteric reflex is remarkably good. Many of you may have heard this, in assuring yourself that if it is present, that torsion is not there. I had been taught, you can't use it 100% of the time, and if it's present, but there's actually only one case report of cremasteric reflex being present in the context of torsion. So it is reassuring if you see it. Only 4 to 8% of cases have preceding trauma. So I had thought it was way higher for torsion. I was fairly surprised. Cycling does not increase the risk of torsion. There was a case review on this, and nor does it increase the risk of epididymitis, which I somehow thought it would increase the risk of both. So that was just an interesting thing. And another interesting thing is to watch for the kid who wakes up in the middle of the night. There's a stage of REM sleep, the sexual stimulation stage, where their blood flow rushes to the pelvic region. This is when we get wet dreams and that, or not me, but and I guess some youth or adolescents would have a higher risk of torsion and then spontaneous detorsing. So if they have that history of extreme testicular pain at night, intermittent, that it may detorse, it may be a history of intermittent torsion. So high five to that doc. Okay, 32-year-old with a history of type 1 diabetes is brought in, and they have been unwell for a few weeks. They also have no real abdominal pain. Pressure's a bit soft, heart rate's a little high, pretty reliable person. Otherwise, they are usually on an insulin pump, so take fairly good care of their diabetes. 2 weeks history of a flu-like illness. Then they went for a massage by the naturopath, which I didn't know naturopaths did massages, but felt nauseous and lightheaded and more palpitations after this. Throwing up, but no real diarrhea and no other symptoms. Vitals, as you see there, but really an unremarkable physical exam. This is the ECG that had been ordered from triage. Does anyone want to take a stab at just describing what they see on the ECG? One of the residents? Ryan, what do you think?
So I'm thinking I need glasses. So looks like they're in a normal sinus rhythm. From this distance, I can see ST changes. The rate maybe around 80, like and I want to say I can't see it, but I'm not sure.
Oh no, fair enough. Okay. So I'll eat a little bit here. So this was read as having a little bit of T wave inversion and ST depression in the inferior leads, and it's hard to say if the sort of the lateral leads like V3 looks a little bit down as well. So this patient did have a little bit of ST depression there, which the physician noticed. These are the labs that came back. So the patient did have a lower pH and some ketones, so looking like DKA. But also, these are sort of interesting labs. So elevated troponin, and then the TSH quite low and T4 quite high. So the physician goes back, because as far as they know, the only medical problem this patient has is their 30-year-old diabetic. And they ask them if about any prior thyroid disorders. And it turns out that they had been taking thyroid supplementation from the naturopath and some porcine adrenal gland, which is trendy these days. And the ERP diagnosed it as a hyperthyroidism triggering the DKA episode. Unfortunately, the patient also did have the troponin that was trended and went fairly high, up to 118. The ECGs never got a lot more dramatic, but it was thought more to be related to demand ischemia. So, just an interesting case. We see a lot of patients in the department, but it's nice when we can figure out a diagnosis, and we have some interesting medical pathology as well. Not as nice for the patient. So tips to take home. Always remembering beyond the Pharmanet to think about other drugs. This patient very willingly volunteered it. I thought that this case was sort of interesting just because it involved multiple body systems and you had to think about the physiology. And first, do no harm in whatever we were prescribing. Nice job. I like how weir is spelled incorrectly, but it was a cute photo. 14-year-old previously healthy with a headache doing homework. This patient was over at MSJ. They had some pain to their eyes that was triggering more of a headache while doing homework. The GP had given some Tobradex drops but felt ineffective, normal vital signs. So the MD notes that she'd had a bit of crusting and conjunctival injection seen by the GP and started on Tobradex drops. It was also in the later notes, maybe the GP had started the Tobradex drops for a sty developing, but anyways, they were on Tobradex drops. No other symptoms whatsoever. The visual acuity was normal. The patient was sitting up doing her homework. It's a very studious patient because homework came up a number of times, but really a normal exam, normal slit lamp exam, normal fluorescein exam. In this 14-year-old, the physician proceeded to check her pressures, which were quite elevated, and checked with another Tonapen because was somewhat skeptical of these initial readings, and the repeat also showed elevated, referred to ophthalmology, and started on an acute glaucoma treatment regimen with the idea that it was possible a steroid drop-induced glaucoma versus a primary cause because she had a grandmother with glaucoma. So it was an interesting case. Tips to take from this one. I think when we have kids and teenagers, where sometimes, there is this tendency to reassure and think that they're otherwise healthy, but getting that proper full set of vital signs all the time, especially if their diagnosis is a little confusing. I know at Lionsgate we had a hypertensive emergency in a 6-year-old, which had kept coming back with abdominal pain for the 4th time, and we hadn't checked the blood pressure. And so the blood pressure was checked, and we sent them over to BC Children's. But it's interesting, because there is this tendency to just do that heart rate and O2 sat, but this physician made this diagnosis by just doing a thorough exam that we would do on any of our adult patients. And glucose in the gastros is another one that comes up quite a bit. Young person's glaucoma. Where does this come from? So more genetic syndromes, autoimmune inflammatory disorders, perhaps a traumatic, so an eye concussion that they were hit in some way with a ball, iatrogenic in this case, we mentioned congenital, and we treat similarly. So nice job, doctor. Yeah. This one was thought to be angle closure glaucoma. Not according to this physician's notes or on, it was more of a subtle one. I only had one resident note from the ophthalmology, and so they had more follow-ups, but you know how sometimes the ophthalmology notes don't all get dictated there, but they had felt that it was angle closure from the steroid drops. We have some really amazing first responders coming in and out of the department, and as Dr. Essler made reference to, I was working on December 30th, and the lovely John Ward was telling me that he had become a really, experimenting with a lot of his cooking skills, becoming much more proficient. As he proceeded to put the sweet potato into the microwave, I walked away, and 10 minutes later, I hear the code red. I walk back, and who do I see? These very smiling, lovely first responders who are helping to rescue a very charred sweet potato out of the doctor's room. I had a grumpy photo, and then I had a happy photo. This is their happy photo. But I thought we have to thank them, and kudos to them. And I couldn't find a high five, but I sort of thought this one was appropriate for our sweet potato. So, just coming back to my father-in-law. He's been in and out of the department a long time, and I have to give kudos to our team. He's had progression of his pulmonary fibrosis. He's got on to home oxygen. A number of you guys have taken care of him. This is Lindsay Wu when we happened to be out of town, and he had to come into the department, bringing him a lot of reading material and food to eat while he was waiting around. Unfortunately, he came back in December at 4 a.m., and very kindly Jessica Blackburn, Jessica Reish, and Frank Schumacher started transcutaneously pacing him when he was in complete heart block, and he has done extremely well, so I have to thank the team for also taking care of my family, the MIT nuclear physicist. Thank you to the team. I think it's sometimes we forget to say this at our rounds. Everyone has a role in this department, and the department wouldn't function without everybody. So ECG techs, nurses, MDs, lab techs, pharmacists, X-ray techs, unit clerks, first responders, security, consultants, social workers, everybody. So as we venture forth into this upcoming year, sometimes we have surges of patients. Sometimes we may feel disgruntled and upset when the department's getting so busy or we're working long hours. But it is important to remember, sometimes you make the diagnosis, sometimes the flow works, and you should give yourself a pat on the back when it does. A lovely patient brought in these very large chocolate boxes on New Year's Eve saying we had saved his life, and then left the department very quickly without leaving a note or a name, but quite nice of him. And then sometimes we deserve and get to drink the champagne. So Happy New Year, everyone, and that's about it.